Hi there, and welcome back to part 2 in this series on arrhythmias and anti-arrhythmic drug therapy. In this second part, I'm going to be talking particularly about tachyarrhythmias, and in this first section, I'm going to be talking about the drugs used in the treatment of tachycardias. Perhaps just to look back at the first part, I'm going to remind you of our simplified approach to arrhythmias. We said last time about if a patient was ill, we were likely to reach for equipment, and that's things like cardioversions. And if they're not quite so ill, then maybe we would consider drug therapy. Before we come on to the individual drugs and the drug classes that we use in treating tachycardias, I think it's important to just look at some of the universal treatments that we would always apply to any patient with an arrhythmia. And we can simplify these into 3 categories, although there's probably more. And these are the management of electrolyte problems, looking for underlying ischemia or infarction that's provoked the arrhythmia, and also considering other underlying causes. Thinking about these in turn, in particular, potassium and magnesium abnormalities are associated with fast heart rates, particularly low potassium and low magnesium states. And in fact, sometimes these alone can provoke ventricular arrhythmias like torsades de pointe. Similarly, people who are having myocardial ischemia or an acute coronary syndrome may develop arrhythmias, and they may need a percutaneous intervention, or they may need oxygen to correct hypoxia, and so on. And finally, always consider whether there's some underlying cardiac or non-cardiac cause, and that might include things like thyrotoxicosis or even structural or functional heart disease. It's probably not necessary as a jobbing doctor to really know much about the classification of antiarrhythmics, but if you look in textbooks, you'll often hear of the Vaughan Williams classification, nothing to do with the composer. And the next slide is a summary of where each drug fits into this classification. And it's a bit of a simplification, but broadly speaking, each drug class will affect certain parts of the action potential, and sometimes more than one. I'm not going to go through these each in turn, and in fact, the whole of this talk will relatively take a simplistic and clinical view of anti-arrhythmic drug therapy. But if you pause here, you can look to see that each of the drug classes we're going to talk about affect the action potential in pacemaker tissues and the cardiomyocytes in different ways. There are a lot of antiarrhythmic drugs, and it can be bewildering, and most of them are small print for your average non-cardiologist, and that's true at the postgraduate level, never mind at the undergraduate level. So I'm trying to simplify things by having an ABCD approach, and this is what you can see on the slide here. The approach I'm taking here is not based on order of importance, but rather just an easy aide-memoire, and you can see I've made beta blockers and digoxin somewhat bigger than the other drugs because you'll use those a lot more. But in short, amiodarone and adenosine, beta blockers, calcium channel blockers, and digoxin account for almost all the average doctor's use of antiarrhythmic drug therapy for tachycardias. There are more, but you'll use them very infrequently and almost certainly with supervision. So first of all, let's talk about beta blockers, and you'll probably dole out more of these than any other antiarrhythmic in clinical practice. So I've created a mind map here, and again, when I put this full screen, you might want to pause to take in some of the detail. But in short, beta blockers are used for a whole range of conditions. Clearly, we're talking about the management of tachycardias here, and that will include supraventricular tachycardias, including atrial fibrillation and flutter, and even for ventricular tachycardias as well. But for cardiac disease, they're also used in ischemic heart disease, both stable and unstable, like acute coronary syndromes, as well as being prognostically useful in the treatment of congestive heart failure. But beta blockers go beyond that, and you will prescribe them in anxiety states and for conditions like migraine prophylaxis as well. Their side effects are predictable, and we'll come back to that in the next part, and I'll also come back to some special properties that are worth considering in a minute. So how do beta blockers work? Well, this is very straightforward here. They clearly work through the sympathetic nervous system. And the sympathetic nervous system comes out in the thoracolumbar spine and innervates a whole range of organs. And you can see here a number of the effects that it will have across the body. Most of them link with things like fight and flight, so tachycardia, bronchodilation, adrenaline, production of glucose, breakdown of glycogen, etc. And beta blockers are going to work by antagonizing these. And so by antagonizing the effects on the heart, we will inhibit the sinoatrial node and the atrioventricular node. That will lead to a decreased contractility, bradycardia, but also a risk of bronchospasm. Due to this side effect, we're often slightly reluctant about using beta blockers in patients with airways disease like asthma and COPD. But you'll notice on this slide that there are some ways around that, but still with caution. There are non-cardioselective beta blockers, which will almost certainly exacerbate bronchoconstriction. But there are a set of cardioselective beta blockers, such as bisoprolol and nebivolol, which have a proportionately less strong effect on the lungs. And sometimes, under supervision, the risks of provoking bronchospasm may be outweighed by the significant benefits of treatment. So that's worth bearing in mind. Moving on to calcium channel blockers, these are a very diverse group of drugs. And if you look in a textbook, you'll see that they are divided into what are called dihydropyridines. These are the ones that all end in pene, so things like amlodipine, nifedipine. And then a second set of drugs called verapamil and diltiazem, which have differing properties. And it's important to recognize that calcium channel blockers are not all the same. If we take the drugs on the left to start with here, you'll see that they predominantly affect vascular smooth muscle. And so they are predominantly used in the treatment of high blood pressure, but also in things like angina as well. When we look across at the effects of verapamil and diltiazem, these are particularly, they have a particular affinity for cardiac muscle and also the conducting tissue like the AV node. And so they are referred to as rate controlling calcium channel blockers. So the drugs on the left will have no real effect on heart rate, but verapamil and diltiazem will. You'll notice diltiazem is somewhere in the middle, and so it doesn't have quite as much selectivity for the heart, but nevertheless it will be useful in this setting. So we're only going to focus on verapamil and diltiazem and their effects on the heart. Just a little recap about what the role of calcium is, and again, this is a real superficial look at this. Calcium is important in the heart for two reasons. The first is it's important for contraction of the cardiomyocytes. So calcium influx into the cells, release of calcium from the sarcoplasmic reticulum is vital for adequate contraction of the myocytes in the heart. But similarly, it's also important during several phases of the action potential and the spontaneous depolarization at the end of phase 4 and also the plateau phase of phase 2 are associated with calcium fluxes, and this is where our drugs will have their action. So if we give a calcium channel blocker, we will reduce the contractility, and that's referred to as negative ionotropy. And that may be a bad thing because that might increase the chances of precipitating things like heart failure. More usefully, calcium channel blockers will slow the excitability of conducting tissue and prolong phase 4, so slowing the heart rate, but also slowing conduction during the plateau phase and therefore making conduction from cell to cell slower, which is called negative dromotropy. Slowing the heart rate itself is called negative chronotropy. And all of these are going to be very beneficial in treating arrhythmias. I'll move on to digoxin now. Most of you will be aware that digoxin is similar to digitalis, which comes from foxgloves. There is a small fact about digoxin that is very useful to be aware of. Unlike virtually all of the other anti-arrhythmic drugs, which are negatively chronotropic, and that's exactly what we want, digoxin is not negatively ionotropic, and this can be used therapeutically if we have patients with advanced heart failure, and they're a group who are clearly at risk of arrhythmias. Digoxin will slow the heart rate down, but not reduce contractility. And in fact, it may even give a little bit of a boost to the inotropic strength of the heart. And this is very useful and should be remembered. Digoxin is really only used in the management of atrial fibrillation and occasionally atrial flutter. So we don't use this for a whole range of different drug therapy arrhythmias at all. Just looking at a quick summary of its action, again, not too much detail here, but it's a cardiac glycoside. It has a large volume of distribution, which means it dissolves all over the body. And so if we want it to work quickly, we have to give loading doses. And it's excreted primarily by the kidney. So we have to be careful in patients with kidney disease that we don't accumulate and get toxic levels of this. Talking about loading doses, this is just a graph to show that we shouldn't expect digoxin to work very quickly if we just give the standard dose. If we give a dose of 62.5 micrograms or 120 micrograms, it will take a number of half-lives, of which digoxin is quite long, before we might reach a steady state and therefore perhaps a minimum effective concentration. This is no use if we want it to work quickly in someone with, for instance, fast atrial fibrillation. If we give a loading dose, however, we can get to immediately therapeutic levels and then follow those up with the standard doses. And this is what you'll see time and again when starting digoxin in hospital in the more unwell patients with fast atrial fibrillation. Moving on to adenosine and amiodarone. You won't use either of these drugs very much, but I want to just have a couple of slides on each of those, and we'll come back to them again about side effects later. Firstly, adenosine. So adenosine is an intravenous agent, and it's a very short-acting anti-arrhythmic. And it's got some useful properties, both to diagnose but also sometimes to treat arrhythmias as well. Physiologically, adenosine will slow pacemaker tissue in the SA node, and in particular block conduction at the atrioventricular node. And it only lasts for a few seconds, so we can use this diagnostically to help us work out an arrhythmia, or at least where the origin of an arrhythmia comes from. This, you may want to pause this slide to go in a little bit more detail, but in summary, this is what we can learn by administering adenosine to an arrhythmia where we're not sure what the origin is. Because we've blocked the SA node and the AV node, if we give it to somebody who has a supraventricular tachycardia, something coming from the atrium, then what we would expect is, because the AV node is blocked, that it will slow down temporarily just while the adenosine works, but it's unlikely to terminate and it will return to its normal pace once the adenosine wears off. Similarly, because it's below the AV node, if it's a ventricular tachycardia, then it's unlikely to be affected in any way by adenosine. And finally, if the arrhythmia is originating and sort of spinning around the AV node itself, a reentrant tachycardia, not only might we terminate that, but we might also get it the patient back to sinus rhythm as well. So when somebody responds very briskly to adenosine, it is a suggestion that the arrhythmia is probably originating, or at least having a circuit around the AV node. So I'm moving on to amiodarone now. Now, amiodarone we'll talk about more in the side effects section next, but you will only really use it in one or two settings. It would be very rare that you will start it as a new prescription. You occasionally might use it in atrial fibrillation under supervision, but the times that you will use it is during cardiopulmonary resuscitation, and so it's used as an adjunct to shocks in patients with ventricular fibrillation and pulseless VT as well. But apart from that, you will not and should not be prescribing this without senior and probably cardiological supervision. So hopefully this is a nice introduction to which drugs you need to focus on as medical undergraduate. I've extended the ABCD to an E and an F here. E is really for everything else. There's a large number of other drugs, but I wouldn't spend too much time focusing on those just now. But I will mention F, and that's flecainide, because you will see a number of patients on flecainide. Again, it's not going to be a drug that you will use, but it's a common anti-arrhythmic, particularly for people with more troublesome arrhythmias that haven't responded to the drugs that are listed, like beta blockers and digoxin. Okay, well, thank you for listening for that. I hope that's a useful overview. In the next part, we will look at the side effects of each of these drugs, and in particular, those that are most relevant to you as an undergraduate and a new prescriber. So see you then.